is entitled The Power of Embedded Coaches for PCMH Practice Transformation, and it is presented by Dr. Jonathan Swartz, Primary Care Regional Medical Director, and Dupe Ajayi, PCMH Change Management Coach from Montefiore Medical Group. Today's session is also moderated by Karen Handmaker, Vice President of Population Health Strategies at Health. Before we begin, I would like to just go over a few housekeeping items. First, you have a control panel on the right side of your screen. You can minimize or expand the panel by clicking on the arrow in the upper right-hand corner. Second, you can submit any questions using the question panel located near the bottom of your screen. We will try to answer as many questions as we can at the end of the presentation. If your question was not answered, we will respond to your question individually after the event. And finally, all registrants will receive a copy of today's presentation and a link to the recording within 48 hours after the webinar. The information will be sent to you using the same email in which you registered for the webinar. At this time, I will turn it over to Karen to begin the webinar. Karen, you may take it away.
Thanks, Renee. We're excited to have so many people on this webinar today. The topic of transforming care teams is very hot, shall we say. I was just at 2 conferences this week and last week where this was a front and center discussion. And the idea is that transforming care teams is definitely an ongoing process and not a check-the-box event, and that is the difference that our clients and our prospects are looking to hear more about. So while having the right technology tools is clearly very important, leadership, culture, care team roles, and workflows are also critical to the mix that allows practices and whole organizations to make the shift from volume to value. So as we will hear today from our client, Montefiore Medical Group, embedded practice coaches are a very effective tactic for bringing everything together and achieving sustainability. So today, as Renee said, our panel includes Dr. Jonathan Swartz, who is a regional medical director for Montefiore Medical Group and oversees a network of 8 primary care practices that see 420,000 visits annually. He recently led the patient-centered medical home pilot program at 2 Montefiore practices and is now working with others to extend this transformation across the medical group. Dupe Ajayi is a change management coach at Montefiore, where she is working with primary care practices daily on their quality improvement efforts and is heavily involved in the group's PCMH recognition efforts, not just for the 2011 standards, but now for the 2014 as well. Next slide. So we're also going to do some polling questions today because we have an audience that is interested in this topic. We want to get a little baseline, not just for all of us to see the answers, but to also help our speakers address your who's on the call and what your concerns are. Renee, do you want to launch those? So the first thing is, do you use practice coaches for care team transformation? Please select one of the answers. Okay, so the first question says that more than half of you actually do not use any coaching, and of those who do, 37% say they are employed by your organization, and 12% say they are funded by a grant or other means. Next question. For those of you who do use practice coaches or are moving forward with care team transformation at your organization, please tell us at what stage your organization is. Okay, so the results show that by far most of you are at a self-described early stage, with 72% saying that, and 16% saying they are very far along. Most practices have actually transformed, and only 12% of you have not started. Okay, the third question, Renee. Please tell us whether you use technology tools to complement your EMR's capability to support your care team transformation. Okay, so now we have the results to this last question, and 57% of everybody on the call say that they do use technology tools beyond the EMR to support practice transformation. 10% says that the EMR does everything they need, and no, 33% no, we need more automated tools to do what we need to do for practice transformation. Okay, that is a great setup for the presentation that you're about to hear on the power of embedded coaches. Dr. Swartz, it's all yours.
Okay, thank you, Karen, and thanks for the opportunity to present today. So for our agenda, I'm going to give a brief overview of Montefiore Medical Center so that you can put the presentation in context. We'll go through our PCH timeline and talk a little bit about our experience with pilots. And then Dupe is going to go into defining the coaching role and how that role has evolved over the last couple of years. I'm going to share a little bit about the physician view of transformation, and then we'll talk a bit about sustainability. Next slide, please. So here are our session objectives. We're hoping that by the time you'll leave, you'll have a sense of the value that the coaches bring to transformation and come away with some strategies. Next slide. So Montefiore is a $3.5 billion organization. We actually have recently been rapidly growing. We now have 6 hospitals, and we have 2 other hospitals in collaborative agreements with us. There are over 170 ambulatory sites of some manner. The medical group, which is our primary care base, is 24 sites. We are a at this point, we have about 270,000 risk lives, either global or shared risk arrangements, and that now totals over 50% of our revenue. Our base has been for a very long time in the Bronx, which, as you know, is a very disadvantaged community with high rates of chronic illness, and we've recently expanded more into neighboring Westchester and Rockland counties. Next slide. So one of the unique things about Montefiore is that we have been managing insurance risk for about 20 years now. And the care management organization is what we call that branch of Montefiore. And they've been really terrific, both partners and I would even say teachers to us around care management. I could easily spend an hour on this slide alone going through all of the programs that they do to assist patients and try to keep them well and out of the hospital. But it's been a tremendous asset for us in the medical group. Next slide. Whoop, there we go. So the medical group itself, where Dupe and I work, is 24 offices. 7 of our offices are FQHCs. I oversee the teaching division where all of the primary care resident training goes on. There's another area we call the neighborhood division. Neighborhood and teaching have similar patient population. We're about 70% Medicaid, 30% other. And then our group practices group, although they are employed physicians, the culture looks a little bit more like hospital-owned private practice. They're about 70% commercial and Medicare payers and 30% Medicaid. I've been back in some version of my current role at Montefiore since 2000, and for the first 10 years, the primary goal of my boss was always reduction of our operating loss. And so by 2010, we were pretty bare bones, and I would even say it was a little bit difficult to be a leader in that organization at that time. We weren't answering the phone very well. We weren't supporting our doctors or our patients particularly well. And with the onset of healthcare reform, the organization has done a pretty amazing 180-degree turn on this. So over the last few years, there's been a $15 million infusion of RNs, which we didn't have in our practices previously, other nursing staff, social workers, health educators, and has really allowed us to begin to actually practice in a team basis. We also are grateful to have a core performance improvement team, 6 coaches. DuPay is one of them, but importantly, we also have 4 data analysts and 2 project associates. Our ability now to produce good performance data has been critical to our success. Next slide, please. On this next slide, I'm going to take you a little bit through our timeline. Back in 2009, we began planning for our we piloted at 2 large sites, one a residency practice, one non-teaching site. And with a $1.8 million budget to infuse quite a bit of staff into those sites, we implemented the pilots in 2010. We hired a manager for our PCMH program who actually, at the time, I thought would kind of function as a coach. And we got the entire organization recognized under 2008 standards as PCMHs, mostly level 3. And of course, as many of you know at that time, without transforming a paperclip. In 2011, we began rolling out a plan to spread PCMH across our network over 3 years and had a $15 million budget to do that. But in late 2012, New York State Department of Health came out with a large grant program, the Hospital Medical Home Grant, which was intended to both encourage and assist teaching hospitals in turning their residency clinics into patient-centered medical homes. But one of the effects of this was that we now had a new target date for completion of PCMH recognition in all 11 sites that took place in the grant by the end of 2013. So we were suddenly kind of tasked with doing in 2 years what we had planned to do in 3 years across our network. At that time, we hired and trained the coaches, and coincidentally, Montefiore then started its Pioneer ACO. So that was, 2013 was an extremely busy year for us, but we were successful. By the first quarter of 2014, all of our sites were recognized. And of course, now we are moving on to beginning to look at the 2014 standards for recognition again. Next slide, please. So I'd like to just talk a little bit about our experience at the pilot sites. We really started this before we had the manager or any of the coaches on board. I actually led some of the planning at these sites, and we put together multidisciplinary planning groups and began to develop new workflows based on the fact that we had new staff to help us, and we're focused on several chronic illnesses and on how we were going to manage transitions from discharges. And I have to say that the work went slowly and unevenly. And some of the barriers were, of course, everybody there would come together for the planning group, but they were also all doing their day job, so that some of the between meeting group didn't always get well accomplished. At that time, we did not have a lot of performance data. We had almost none. And one of the effects of that, of course, was that when we would roll out a new workflow, the individual performance in different parts of the practices was variable, and we really didn't have any good way to track that. As we went through PDSAs, I don't think we didn't really have enough staff to supervise them well to make sure that they were completed and the data was gathered. And at that time, we were, I think, not paying enough attention to the PCMH standards in the work that we were doing. During that same time, the PCMH manager that we subsequently hired, who I had thought would help us with coaching at the sort of the end of those pilots, really got pulled into the large job of getting all the other sites recognized under the 2008 standards and planning for our subsequent expansion over the next 3 years. Next slide, please. So I'd like to turn it over to Dupe at this point to talk a little bit more about our PI infrastructure and what it means to be a coach.
Thank you. And thank you, Karen, for inviting us to share about our work at Montefiore. My name is Dupe, and thank you, everyone, for joining. I'll be speaking in more detail about coaching. But before that, to provide you with some context around our coaching work, here on our slide, you'll see our transformation focus areas, and we can categorize them into 3 primary bucket areas. The first pertains to the NCQA PCMH recognition process. And really there, we've done a lot of work around sustaining changes made under the 2011 NCQA standards. And now we are in the midst of preparing our practices for the new sets of standards. And I have that bolded, preparing sites for the 2014 standards, because that's a major focus area for us this year. All of our sites were recognized under the 2011 standards between mid-2013 and early 2014, and that was a pretty large coaching undertaking. But since then, we've worked on sustaining improvements made as a result, and we've conducted formal internal audits and then more informal check-ins to help with that sustaining process. And now, as we're gearing up to meet the 2014 standards, the entire coaching team is becoming well-versed in the standards. We also have a project associate who is sort of our in-house expert on both the 2011 and now the 2014 standards. And together as a team, we're beginning to do a gap analysis and develop an approach to working with our practices to meet the standards. So that's our first bucket area. Then our second focus area pertains to organizational quality improvement, which we actually started focusing on more so in depth after we completed the 2011 recognition process. So as an organization, we have a set of quality measures. So they pertain to areas of chronic conditions, the patient experience, pediatric and preventive care, et cetera. And we have targets set out for many of them. So in addition to working on that, we are also in the midst of a transition to a new EMR system. And that's a major focus area for us right now, hence the bolded text there on this slide. The coaches have been involved in identifying key workflows for replication in the new system, and those include key workflows that were developed to satisfy the 2011 NCQA standards. So in the days and weeks leading up to our go-live on the new system and following the go-live, the coaches will be supporting the replication of workflows based on functionalities that are in the new system, which is Epic, as well as working with the practices to craft workflows that will meet the 2014 standards. And the coaches will also be instrumental in identifying gaps in the transition and then facilitating overall change management. So then our last focus area, and a very important one, is the category of team functioning, because that is truly foundational for sustainability, as you all know. So let's move on to the next slide. And this pertains to the nuts and bolts of the coaching role. So how do the coaches support those 3 focus areas I just spoke about? We really serve as champions to facilitate change at the site. So as you can see from that word cloud there on the slide, that involves a lot of different tasks. So I have our main responsibilities listed here on this slide. We spend a lot of time facilitating or participating in interdisciplinary team meetings at the sites. So those meetings, they're focused on review of standards, discussion of quality measures, designing tests of change and PDSAs, designing and evaluating workflows, following up on action items, review of data, and troubleshooting. So we spend a lot of time doing that. And then outside of those meetings, we also spend time on training staff on various areas. So for example, if a new workflow was created, we'd spend time training with the staff on the new workflow. We also are involved in project management, working on transformation strategy, and then planning organization-wide learning collaboratives. So let's go on to the next slide. And here is a visual of our coaching life cycle. And this is actually a framework we developed as a team based on literature on quality improvement and change management. And this framework applies to just overall transformation as well as coaching on a specific QI project. And I won't go into detail on each of the phases, but I'd be happy to talk about it during Q&A or offline if anyone is interested. But the framework really begins with the needs assessment or identification of the problem. the framework involves forming a team, developing a strategy, workflow design, planning, and evaluation. And it ends with sustainability because true transformation is not complete unless it's sustained. So I'd be happy to speak more on that if anyone is interested. But let's move on to the next slide. To talk a little bit about training. So during the polling, Karen mentioned that about 50%, a little over 50% of you all are not using coaches right now. So, if this presentation inspires you to do so, I will give you some information about what to look for around training and qualifications. So when a new coach is hired, there's obviously some on-the-job training that needs to occur, and that's what I have summed up here for you on this slide. A lot of that training is geared towards getting the coach familiar with the assigned sites or practices they'll be working with. So for example, they'll need to know who are the key players here, what are the practice's key characteristics, how is the practice performing on key metrics, for example. There's also training on IT systems and data and reports, training on QI methods and our transformation focus areas, and then of course there's training on the NCQA PCMH standards. During the hiring process, we do look for individuals who have certain qualifications. So for example, prior healthcare experience is required, some project management experience, experience with data analysis and management, definitely comfort with interacting with the different types of people that are at the practices. So just thinking, back to your practices and the different types of people you have there, we want someone who has the comfort level with interacting with all of them. And then someone who has emotional intelligence, cultural competency, key communication skills. Those are all prerequisites for getting hired as a coach. So let's go on to the next slide. So you may be wondering what makes a coach effective. And in all honesty, an effective coach wears multiple hats, as you can see from here. So in addition to having those qualifications and competencies I just mentioned, an effective coach needs to be able to encourage great performance, as a sports team coach would. He or she also needs to use data effectively to drive improvement. Effective coaching is also related to change management. So if you look down at the picture on the lower left-hand side of the slide, how do you get a person or a team from the state of resistance to the state of full investment in the change? And then sometimes a coach may need to step in as a negotiator, mediator to encourage teamwork. So those are some of the things that make a coach particularly effective in coaching. So let's go on to the next slide. And here in sum is our quality improvement structure. We have a team of coaches, data analysts, and project associates, and we all, which I don't have on this slide, but we all report up to an associate director and a director for performance improvement. And as a team, we discuss experiences at the practices as a way to share best practices amongst us, to troubleshoot and problem solve common issues that come across multiple practices, and also to determine data needs. So you may be wondering, if you are interested in getting into this, and how can you make it work? I think coaching is a necessity for true transformation, whether that coach is someone you've hired specifically for that purpose, whether it's an external consultant or it's an existing employee who can serve as a change agent. Just one thing to note is that using an existing employee can be difficult because of the time constraints, which John mentioned earlier. Everyone is busy doing their day job, so it can be really difficult for that person to be able to facilitate change and quality improvement at the same time as their day job. Another thing to note is that you'd also want someone who can be able to incorporate the interests of all disciplines. So you'd want someone who can be unbiased in that respect. But however you set it up, coaching has really proven to be really necessary for true transformation. So in addition to having this team of coaches, data analysts, and project associates, the coaches are assigned to a group of practices that they work one-on-one with, and then the transformation is disseminated within and across practices, as you can see from this visual. So let's go on to the next slide. So coaching is all about continuous quality improvement, and we really need data to make that happen. One of the tools that we have in our coaching tool bag is a suite of reports that can be used to monitor improvement, and it can also be used for population health efforts. So just for example, we have a diabetes registry, we had asthma reports, we have preventive care reports, and these reports come along with work lists that can be used for outreach. So on the next slide, I'll show you some examples of improvements we've seen in primary care since we began this transformation journey. So here, just one of the examples of the improvement we've seen, this one here is in documentation of pneumovax administration. And some of those improvements can be attributed to improvements in documentation within our EMR system, as well as increased outreach efforts, and then involvement of LPNs and medical assistants in visit workflows to ensure that patients are receiving their recommended preventive care. So the coaches played a key role in helping the practices develop workflows around those areas. And these improvements you see here, have continued to this day. So let's go on to the next slide. And here's just another example of improvements we've seen in depression screening rates. And again, those improvements have continued to this day. And then if you go to the next slide, we've also seen improvements in hospital readmission rates. So this graph here shows the readmission rates for Medicaid patients at 10 of our sites that were part of the New York State Hospital Medical Home Demonstration Program. And all the patients were pre-identified as being at high risk for readmissions. An improvement you're seeing here that can be attributed to involving chronic care RNs at the practices and care coordination and outreach to these high-risk patients. And again, the coaches played a role in helping the practices develop workflows around outreach to those patients. So let's go to the next slide. So the ultimate goal in transformation, as I mentioned earlier, is sustainability. And a great deal of that does rest upon team performance. So here on this slide, you sort of see the trajectory of coaching intensity and how that interacts or intersects with team performance. Typically, teams that are not performing, that great will get more intense coaching, and the intensity of the coaching that's characterized by frequency of meetings with the site, the amount of time spent at the site, things like that. But as a team's performance improves, coaching intensity can lighten up, as you can see from the slide. So in addition to depending on team performance, coaching intensity can also depend on the specific area that's being worked on. So as we begin to prepare our practices for recognition under the 2014 standards, many practices are going to need the intense coaching again just to get them started. So if we go on to the next slide, I'm going to actually turn it back over to John to talk about the physician perspective on transformation and financial sustainability.
Thanks, Dupe. So I wanted to talk a little bit about how our physicians viewed this process. And so before transformation, we were well-versed in the primary care hamster wheel. It was all about how many visits you could produce. And of course, naturally, we were very focused on whoever's in front of me in the exam room. The fact that one of my patients was in the hospital, didn't show up, hasn't been in 6 or 9 months, was not part of my kind of daily work routine. We didn't have quality or panel data to look at our performance or to use for outreach. And so one of the initial reactions to transformation and the entry of the coaches was, well, I'm already on the EMR till 11 at night finishing my notes. Why are you giving me more clicks to produce this supposed care plan for PCMH recognition? And initially the coaches were kind of seen as PCMH cops, remembering that during that time we had tremendous time pressure on us to complete recognition. As things moved along and as we have evolved, there's been really marked changes. We are now doing more in each visit and having fewer visits. We have successful quality initiatives. We recently changed our physician compensation model last July to move away from volume and place a lot more incentive dollars on quality. We are really able to take a team approach to working with our patients, which has been really gratifying as a physician. I now know a lot about my patients. I get a work list every day of all of my patients that were admitted or in the ER or when they were discharged. And I now have staff to do outreach to those folks if I think that, that it's important. We have tremendously good data reports on the, these areas up here that are on the slide. And as Dupe said, it's not just looking at performance. We also have work lists there for people that have care gaps that our PCMH staff can now do outreach to. So we moved from, PCMH coach as cop to please don't take away my coach, as things began to wind down and the coach may have moved on to spend more time at another site. We haven't quite hit nirvana yet. We're still dealing with a lot of EMR overload and our physicians feeling stressed by keeping up with that documentation, have tremendous patient demand to deal with. And one of the surprises for us was that New York State nursing regulations are very restrictive about what LPNs can do. So many tasks that we believe they are capable of doing, they're not allowed to do under these regulations. So, for example, some of the routine lab tests on diabetics, or even things like getting a urinalysis on somebody that's coming in with dysuria, they're not allowed to take those actions without getting an order first from the physician. Next slide, please. So let's talk a little bit about sustainability. I think we are in a very unique position because of the amount of risk contracts that we have, which is helpful. In New York State, Medicaid pays $6 per member per month if the patient is receiving their care in a level 3 PCMH. In our ACO, the first year in our ACO, we had about 120,000 lives, and we actually were the most successful in the country in terms of savings against benchmark, saving $24 million, and $14 million of that then came back to Montefiore. We've seen, since we've implemented our PCMH, that about a 10% reduction in preventable admissions and readmissions in our risk business. That's worth over $5 million to us. Many of our payers now have quality incentives, fairly substantial quality incentives related to HEDIS or QAR, which is the New York State Medicaid version of HEDIS scores. And we are working on improving those scores, but those are potentially worth several million dollars to us. We have seen that as our visits have become longer and more complex, we've begun to use external coders, and that's brought in about another $8 per fee-for-service visit. And although we haven't moved on to take advantage of some of the new Medicare fees, I know at the FITEL users group meeting that I attended this year that a number of groups are using FITEL to identify and outreach to those populations as another potential revenue stream related to doing transformed care. Next slide. So lessons learned, certainly it's important to communicate the vision for transformation across the organization. That needs to start at senior leadership and work its way down. It's, I think, helpful to start small. And I think in our pilot found in working with the coaches that it was really helpful to get a few solid early wins and then build from there. As I mentioned, having data is absolutely critical for achieving change. And to the extent that you can invest in a coach or a consultant, we initially brought in a consultant to help us train our coaches at the beginning. It has been tremendously helpful to us. And then lastly, getting buy-in across the organization. And I'm going to say a few words about this and then turn it over to Dupe, because I think we look at this a little bit differently. I won't speak for her, but will say that I agree with her point of view as one of the important ways to get buy-in. But from my perspective as a physician, I think the coaches really earned the buy-in. They brought such value to the practices and to the teams in that nuts and bolts list of tasks that she was talking about, that the managers, the physicians who started out skeptical became just felt like they couldn't live without their coach. So at that, I'll turn it over to Dupe for a final comment.
Thank you. So my final comment here is, and this is where we differ a little bit, is from the coach perspective, the process does move a little bit more smoothly and easier if there's buy-in before the coaching begins. But the way it actually ended up working for us was that the buy-in was obtained by just proving the value of coaching. So, once everyone saw how much value was being added to the organization, and when people began to see the improvements, some of which I mentioned here today, they really began to realize the value of coaching. But if it can be done the other way around, I think the best way to get the buy-in is really just establishing the sense of urgency around the need for change, and being really specific and direct around the role of the coaches, and just messaging that effectively across the organization. So I believe that's all we have for you today, and I will turn it back over to Karen.
Thanks, Dupe and Jonathan. That was really, really helpful. Now we're going to go to questions, and my screen is filling up with some really great ones. So while you enter your questions, I just wanted to make a couple of general observations and ask you a couple of questions of my own. So what we see at Phytel in all the work that we do with organizations, and we've gone and visited the practices at Montefiore as well, and Montefiore uses some of our products too. If there is no one coaching, if there isn't anybody doing this work full time, as Jonathan and Dupe said, it really is difficult to see change, and more likely what we see are lots of stops and starts and lots of frustration. So the coaching, while it is an investment, it really is a way that we've observed, not just at Montefiore, but across many organizations, that when you do have it, it makes a noticeable difference, major acceleration, major change in culture, versus if you don't, it's really hard to get out of first gear. So one of the questions that I have for you, Dupe, is sort of a complement to the slide that Dr. Schwartz did on on the MD's perspective. So maybe you could talk not really about the coach's perspective, but the rest of the care team's perspective on how daily life has changed with in the transformed model. In other words, we always hear about the goal of getting everybody to the top of their license and reducing turnover and improving staff satisfaction, and whether things like being able to automate certain tasks, like calling patients for who have care gaps like we do for you, or having your data analyst do some of the crunching on the numbers rather than trying to ask nurses to go through spreadsheets. Can you comment at all on that side of the coin?
Sure. So I've heard some great feedback directly from the care team members at the sites. I think one of the things that, one of the sentiments that's shared across the board is just appreciating being involved more directly involved in care transformation. So we facilitate these interdisciplinary team meetings at the sites where you have your front desk staff, your MAs, who are really able to speak from their day-to-day experience and use that day-to-day experience as a way to provide suggestions and recommendations for how changes can be made. And then their recommendations and suggestions are actually being listened to. We're taking them and using them to create PDSAs and tests of change, and we're evaluating it. So from that perspective, there's a whole lot more investment, not just from the providers, but from everyone else at the site around care transformation. So that's one of the biggest, I think, for me, things that are gratifying to hear directly from the care team members around this role. One thing, though, about the sustainability is we are trying slowly but surely to get those at the practices to sort of take on some ownership for some of the areas around following up on action items, for example, because that's where we see transformation going overall. So from that perspective, yeah, you often need a coach there to make sure that the changes are being sustained, but to the extent that we can, I think we have been successful in some regard with this, being able to transfer some of that action item tracking or project management back over to the care team members so that those changes can be sustained and they can own that sustainability. I think that's key. Did I answer your question?
Yeah, that was great. Okay, now I'm going to go to questions from our audience. So for you, Dr. Swartz, some folks are saying that getting physicians to buy in, as you indicated, is not easy. But even when there's a lot of traction and we're making progress and we're seeing some outcome changes, ultimately there's still some doctors who don't want to come along. Any suggestions on how to bring the rest on board?
Yeah, that's a great question. So I think that we certainly saw a lot of this on our journey of physicians resistant, not willing to kind of partake in the team process, trying the new workflow for a day and then saying no and going back to their old ways. And so I think there are a couple of things that helped. One was having a number of our measures focused on quality, I think brought doctors along who otherwise may not have been willing to invest. And then, of course, there's always a role for physician leadership at this point that, some doctors may need a critical conversation in order to get moving. But I do think that the number of those that we ended up having really lessened as the momentum started moving more quickly. And I think the other, thankfully to our leadership, our chief medical officer, who I report to, making an investment in physician compensation related to quality, I think, has also really helped bring people along.
Okay, that's great. All right, now, Dupe, this one might be for you. A lot of questions are coalescing around what is the staffing model? How big are your panel sizes per physician? What does the average care team look like in your practice? How many practices do you have? Can you run through a thumbnail sketch like that for us?
So I think probably John can answer the question around panel sizes better than I can.
Okay.
So do you want to take that piece? Dr. Swartz, are you there?
Yeah, sure. So, yeah, I'm here. Can you hear me?
Yes.
Yeah.
Hello? Yeah, okay. So, yeah, I think panel size depends on how you look at it. I think, our practices are very mixed between capitation and fee-for-service. Also in our teaching practices, because of the turnover of the residents, attribution of the PCP is more challenging. But I would say, as a thumbnail, what we use to define panel in all our reports is the unique patients seen in the practice in the last 18 months. And looking at it in that way, a typical family physician is around 1,400 patients. Now, that's smaller than an insurance panel because not everybody on your insurance panel comes in. And in those sites where we have highly capitated membership, those doctors, looking at the panel from the point of view of the insurer, those panels are quite a bit larger. Dupe, I think part of the intent of the question was to kind of hear sort of your workload in terms of how the care teams what are the care teams in your practices? So I'm going to pass that one back to you.
Sure.
And also, Dupe, how many practice coaches for for each practice coach, is it one practice per coach, or I think you mentioned earlier that might be several practices per coach, depending on level, right?
Yeah, sure, I can speak to that. So the assignment of coach to practices really depends on kind of like the composition at the practice. So for example, we have practices that have pediatrics separate from internal medicine. Then we also have practices that are family medicine, so they don't have that that same kind of separation in department. So if we're looking at it from that perspective, the ideal assignment would be about 4 to 5 teams per coach to work with. And that really allows the coaches to do some intense coaching with some of the teams that need it, and some more moderate to maintenance coaching with the other teams that may be further along. Currently, I'm working with 3 practices that each have 2 teams, because they have their internal medicine team separate from their pediatrics team. So that would be, for me, a total of 6. But some of the other coaches on our site have a lot of sites as well that they're working with, and they're just able to balance it because there are some teams that don't require as much intense coaching, so that frees up some time so they can provide more intense coaching to the teams that do need it.
Okay, that's helpful.
I'll just throw in just to give a little perspective. So our practices range tremendously in size. Our smallest practice, I think, has 3 physicians, and our largest teaching practice has about 100 residents and I think 50 or 60 faculty.
Okay, and Dupe, can you mention again? Lots of questions around the type of staff. I know there is really no average model because, like Jonathan just said, the sizes and scope of the practices can vary, but how many care managers, or what are the ratios of MAs to physicians and LPNs or care managers? Is there any profile you can offer that would be helpful?
Yeah, so it really depends from practice to practice. Again, just how many providers do they have on site and what their model is like. Some of the practices, especially the smaller ones, there is like a 1-to-1 ratio between a physician and LPN or MA. But then for some of our larger practices, it's not 1-to-1, right? So they'll have attendings and residents practicing, and they may have a group of nurses, LPNs or MAs who are supporting them. And then we have front desk staff. And again, in some practices it is 1-to-1. So you do have one particular front desk staff person who's working with one nurse who's working with one doctor. But then at our larger sites, that's not the case. So it is one front desk staff person who's working with a group of providers, physicians, and doing the front desk administrative work for them. And then some of our sites have registered nurses who serve as our chronic care nurse managers. And typically it's 1 or 2 per department. So if you have like pediatrics separate, then they may have 1 or 2 chronic care RNs, and in internal medicine you may have 1 or 2, or if you have a family medicine site you may have 2 covering the whole site. And then many of our sites also have social workers now, nutritionists, certified diabetes educators, and again, typically it would be 1 or 2. For the larger sites, though, there may be a team of social workers who are there on site. So it really depends. It's a wide mix, as Dr. Swartz mentioned.
Mm-hmm. And another question that we're getting from quite a few people is around training tools, curricula. did Montefiore write the book for yourselves? Did you start with a pilot and then roll it out? How, I think you had a slide on that at the beginning of the presentation, but some people joined late too. So, again, is it all pretty much built, or are there resources you can recommend?
So we did start off as a pilot, and our coaching team is larger.
Well, I think, early on.
Sorry. You want to go ahead? Hello?
No, go ahead, Dupe.
Okay.
I'll follow you.
Okay, no problem. So we started off as a
go
pilot.
Ahead, Dupe.
And our coaching team is larger now than it was when it first started. And we did work closely with our supervisor at the time, and she referred to a consultant who had a lot of experience with coaching. So we didn't have a specific curriculum per se, but there were materials that we were able to refer to on just practice coaching and QI in general. But if anyone is interested in specific resources or materials, I'd be happy to sort of share some of the resources that we've used in our coaching for those who are interested. But we don't have, as of now, because that's actually something we are working to put together, but we don't have a curriculum per se, but we do have pieces of a model, like so the coaching life cycle that I showed earlier. That's something that we're sort of crafting and refining as of now.
Okay, that would be great, Dupe. Maybe what you could do is just send us a couple, and then Renee and I will send that out to everybody who's on the call. Just,
Sure.
If there's a couple of key public resources you wanted to share.
Sure.
Okay, and here's a question that makes perfect sense, and given that we're talking about the patient-centered medical home, we haven't talked much about the patient per se, or how you've noticed the patient perspective being considered or improving, how patient satisfaction, et cetera. How are you finding that patients like the transition?
Dr. Swartz, have you gotten any feedback directly from?
Yeah, I think there are, there are certainly indications and feedback from patients, mostly positive, that, there's, when we are kind of following up on them, say after a hospital discharge, I think people are happy to get that attention. With some of our more chronically ill patients, they've really developed relationships with the chronic care RNs. And so I know that they've seen that addition to the practice as something positive. The potential negatives are some patients are so used to communicating just with their physician that they had to kind of get used to having other team members involved. But I think largely it's been a positive reaction from patients because they feel that they're getting more care from us.
Mm-hmm. And I just want to add that most of our sites now at this point have patient advisory boards, and patients are providing their feedback that way. And for the most part, the feedback is very positive. But during those meetings, we're able to get feedback on specific initiatives that have been started at the site or specific workflows, and then we're able to get feedback from the patients about those. And those have been generally positive, but then they've also offered opportunities to tweak practices at the site based off of feedback they've gotten from the patient. And then we are using the CAP survey to get feedback from patients as well. And we are tracking that on a regular basis. I think that may have put that on our slide around our transformation focus areas. So the patient experience is one of our focus areas and something we're following closely.
Okay, that's really helpful. Jonathan, here's another culture question for you, or I interpreted it as a culture question. When you do share quality performance data in the organization, do you identify the individual providers? Do you share it at the group practice level and at the individual level? I know that's a PCMH requirement, but how does that go in real life?
Yeah, we do both. And actually, I would say a little bit before our PCMH transformation, we started working very hard on patient satisfaction. And we just really have always held to a rule of transparency that information is shared to the practice and at physician level. So those things are available publicly.
Okay. One last wrap-up question, since we're getting very close to the top of the hour. With regard to technology generally, since we asked that question of everyone on the call, if Dupe and Jonathan, if you could each take a last comment on the role of technology, just broadly. So I know obviously you have an EMR, we know that you use some FITEL tools, but just how important is data analysts, and the technology available to do patient engagement, all of those functions, how important has that been in your transformation?
So I'll
or
start.
Put another way, could you do it without it?
Well, I think it makes a lot of our efforts, easier, of course, and then being able to have the data to track our improvement. I don't think we would have gotten this far if we didn't have the data to show where we started from and where we are now. So I think it's integral. I don't know how we would have done it without the technology that we have available. Okay.
Yeah, so I would say there's two aspects that are really important here. Certainly, the EMR has allowed us to communicate among team members so much more easily than we did in the paper world, and it also allows us to work remotely. So, we may have a certified diabetes educator that covers several sites. She doesn't need to be on site for me to communicate with her or her with me about one of my patients. And as I mentioned before, I think the ability to analyze data at the practice and physician level was just crucial to allowing us to move forward. If you don't know where you're going, it's very hard to know whether your efforts are really working or not. Lastly, I think we have used FITEL for a couple of outreach efforts. One is to automatically bring in patients with care gaps, and the other was on our hospital medical home project. We had to do a care transition survey to discharge patients. And that, I think, clearly we could not have pulled off without FITEL. And I do think that this is an area that we have not yet fully exploited. One of the other interesting things to me at the users group meeting was that some organizations are using that kind of automated outreach and analysis sort of kind of in the place of human resources, or giving you the ability to focus your human resources on the people who really need that touch.
That's really helpful. Thanks a lot. And then I just want to, there are lots of questions that we got, and we haven't been able to answer all of them, but I do want to point out that many have been about the type of coach. It's more of a patient coach, like a health coach, versus a practice coach. And maybe, Renee, we should do a separate webinar on health coaching. But the practice coaches don't necessarily do any patient-level interaction, but they enable the rest of the team to spend more time doing that. So want everybody on the call to make sure that you understand that while there are lots and lots of coaching that's needed to do this transformation, and there are different types. So thank you very, very much, Dr. Swartz and Dupe, Ajayi, to do this webinar for us. I'm going to turn it back over to Renee for the final slide.
Great. Thanks, Karen, and thanks, Dr. Swartz and Dupe, once again for your time today as well. This information is extremely invaluable. We just want to remind everybody that you'll receive a follow-up email which will include a copy of this presentation and a link to the recording. You should receive it within about 48 hours. And again, it will be emailed to the same email in which you registered for this webinar. If you can, when you log off, please take a brief survey to let us know how we're doing so that we can learn a little bit more about what you think and how effective this particular presentation was and how we can improve in the future. We really do appreciate it. Our next webinar series will be on April 29th from 12:30 to 1:30 p.m. And it will be on population health using automation campaigns to educate, support, and coach your whole population. It will be presented by Terry Coleman, who is the practice administrator at the Charleston Internal Medicine Group. So again, thank you everyone for your participation today. We appreciate it. Have a great rest of your day and a great weekend. Thanks again. Take care.
Thank you.